morning, everyone. I must thank Dr. Bhalla for inviting me here and the AIOC team here who has done a wonderful conference this time. Beautiful food arrangement also. Plus the local organizing committee, I must congratulate them for doing such a wonderful job. So my topic is achieving a 2020 with a posterior capsular end, PCR in short form. So I hope anybody who's operating this dreaded complication once in a while can happen or may happen, especially when you are in a teaching institution, you see these things day in and day out. So what are the risk factors of a PCT? If initially you see there is a poor visualization, cataract which is posterior polar or a posterior traumatic cataract with a tilt, subluxation or a small pupil and weakened zonules, or if it is a vitrectomized eye, that is the point to become cautious. And if you are not a very good surgeon, try not to do such cases under topical anesthesia. I am mainly a topical anesthesia surgeon, but if such cases come and we are sure that something may happen, then try to give a local block. So what are the predisposing surgical factors? Surgical factors could be a small capsular excess, not the exact size you intended. It could be an extended capsular excess, it can happen once in a while, uncontrolled hydrodissection, surge in the faulty machine, running after small pieces, or improper IOL insertion. I have given highlights of what can happen during surgery, even if pre-op there was no problem. So what are the signs of impending catastrophe? When you are operating, if there is a sudden deepening of anterior chamber, go slow, stop, think what is happening, what you might do, what can be done to correct the things, dipping of one pole of the nucleus or altered reflex in the periphery. So what an anterior segment surgeon can do? Zonular dialysis, like I told, can take place at any stage or with any surgeon at any time in his life. I have been operating for last 25 years now. Still, I am not free of any PCTs or PCRs, although they are very, very rare, but it can happen because the more senior you grow, the more complicated cases start coming to you. So it can happen with any surgeon. The thing is not to panic. I myself am doing retina also. I do retina as well as cataract, so panic in my cases are less because if there is a problem, I myself can do the complications and operate them. So a PCT always does not mean that there is a vitreous loss. I'll show you a video how to avoid vitreous loss. So maintain the anterior chamber, don't panic, don't take out the phaco probe in a hurry. Use viscoelastics liberally. If there are any problems, use viscoelastic. Viscoat is the good viscoelastic. Do a dry aspiration in case if there is a problem, and in case of zonular dialysis, use an endocapsular ring. So this is a small video. You can see here, this is a posterior polar cataract. Already this is being done in the local anesthesia, no topical for such cases. So you can see a hydrodissection being done, and now you can see I am taking out the nucleus, and you will see somewhere in between there, that is the rent you can see there. So you can see this popping out. The vitreous has not come out of the anterior chamber, and doing a slow aspiration with the help of viscoaspiration. This is called viscoaspiration under viscoelastic, and now extending the posterior axis because wanted to remove that bad part of the posterior capsule. So after that, a shallow vitrectomy, removing the Visilon. The vitreous has still not come out. And then you can put a IOL and do an optic capture. And the end result is very good vision. Vitreous did not come out, although we have just shaved the vitreous at the bottom. So you can see a good result, patient happy next day. So what happens if there is vitreous in the anterior chamber? Please do not use the phaco probe to remove the vitreous. It will keep on pulling and tugging, and you can cause rents and tears in the retina. Clean the vitreous around the nucleus and do a dry vitrectomy like I told, and visco-assisted vitrectomy, that is the rule. No fluid. Basics of management, what is the common mistake we do? We suddenly, when we see something is happening, we withdraw the phaco probe. If we withdraw suddenly, don't maintain the chamber, the vitreous will tend to come out. We want to leave the vitreous in. Never let the chamber collapse. Conventional methods like cutting with a scissor like we used to do with a Merosil sponge. Earlier there were no good vitrectomy machines, but nowadays all phaco machines also have a good vitrectomy. The main problem is, although the machines have the vitrectomy cutter, this I tell in every session, the cutter is not available at the time you want to do the vitrectomy. Always keep 1 or 2 brand new cutters in your store, that is important. So cutter, new cutter always should be there because machine has a cutting facility, but we don't have the cutter, then what to do? So automated vitrectomy is the right choice. So where is the problem? Problem is in our head. You don't have to worry. Anybody can do it. It is a very simple procedure. And basic principles are cut before aspirating. Don't aspirate, cut before aspirating. No pulling, no hydration. Balance the fluid egress. The chamber should be maintained. Direction of the cutter should be anterior, not posterior. And section and anterior chamber should be the vitreous free zone at the end. And automated vitrectomy, again I'm telling, preferably a new cutter. The rules of anterior vitrectomy are bimanual irrigation and cutting, remove vitrectomy completely from the AC, free the corneal and scleral wound, and free the pupil. These are the basic points. You can see an older video which I have got. This is again a relatively small pupil, moderate cataract. So rhexis size is little small. Ideally, we should have used pupil expander, but this is around a 15-year-old surgery, old video which I had. Relatively grade 2 to 3 cataract, doing the hydrodissection. So you can see what happens during surgery also, you can create problems. So this is the nucleus being aspirated, phacoemulsified, and now you can see what is going to happen. This is the epinucleus. This is the time when you have to be most careful. I tell all my residents to be careful at this point. See, this is what has happened. Again, a small rent you can see, the phaco machine, sudden surge, and there it goes. So you have to be careful when these things happen. This is how we do a dry vitrectomy, again using viscoelastic, aspirating using lot of viscoelastic aspiration with a cannula, and doing the anytime the vitreous comes, try to cut it in between, remain in the center. So these are the basic principles. So after this you can put a IOL also. So what are the more ticklish problems? Nuclear pieces in vitreous. Sometimes what happens, this was just a small rent. What happens is the nucleus, there are pieces of the nucleus, they keep on rotating all around. They are going back, they are coming around. Whatever may happen, don't run after the pieces. You will be more tired and thirsty. The more you run after them, the more problem they will create. So if you are not a qualified vitreous surgeon, please don't go ahead. You can leave it at this stage. There is no need to panic. If there is no vitreoretinal surgeon available, just close the case and leave it for the vitreoretinal surgeon to complete it. The end results after a few days will be the same. You don't have to worry, but the thing is to tell the patient what has happened. That is important. What you should not do is try to remove the nucleus pieces and put wire vectors in the vitreous. Sometimes we have tendency to go in and come out and take the whole pieces out. That should not be done. So management, same sitting. If you have a VR surgeon or you are qualified vitreoretinal surgeon, or deferred, refer to your surgeon friend, vitreoretinal surgeon friend. He will give a good result. And don't worry, vision, most of the time, most of the cases I have also operated, people get good vision. Your present imperfect handling of vitreous may make your future tense. And what you can do is anterior vitrectomy, cortical cleaning, IOL, if you are okay with it, you put it, otherwise your vitreoretinal colleague can put the IOL for you. And last but not the least, another very old video, what not to do is shown here. This is around 20-year-old video.
Neeraj, can you summarize, please?
This is last slide, sir, one slide. This is 10 more seconds. So this is what you are doing. See, I am taking out the already rent is there. You can see we are taking out the vitreous, doing a aspiration and vitrectomy. You can see the big nucleus there. There is a big, huge nucleus there. What is going to happen is, see, it is going down. It has gone down. My message is, if it has gone down, let it go down. Leave it for the VR surgeon. Don't try to pick it up. And then you can, at the end, put the lens if you want. And this is my message for surgeons for achieving a 20/20 again. Do not fish for the nucleus. Thorough anterior vitrectomy. Remove cortex with dry aspiration. IOL insertion only if you are confident, and refer to a vitreoretinal surgeon.